Good morning, everyone. You please take your seats. I would appreciate it. I'm Senator Walter Michel. I chair the Insurance Committee in the Senate. We're going to go around the room in a moment and introduce everyone, but I want to tell the members of the committee that in your packet is a list that I would like you to please fill out of suggested future topics and someone that might be an expert on that subject that you would recommend. It's very important that all the members of the committee have some input on that. So during the meeting today, please fill that out and hand it in to me at the end of the meeting. I would appreciate your help very much on that. A purpose of our committee is the study of health benefit plans and healthcare services. Senate Bill 2401 was set up to be a committee of 11 members for all walks of life in the healthcare industry. And what I'd like to do first is for everyone to know is to go around the room and for each person to introduce yourself, and please give a little bio information on yourself. And I guess we can start with Dr. Lampton on the Zoom. If you would please go first, we'd love to learn about you, Dr. Lampton.
It's an honor to be here, and my apologies for not being there in person. I had some medical issues at the clinic come up, and I couldn't pull away all day. I'm Luke Lampton. I'm a family physician for 30 years in Magnolia, Mississippi, practicing bread and butter family medicine. I also serve as chairman of the Board of Health, and I deal with insurance issues regarding our patients every day. And I'm very pleased that we're looking at this issue, and I'm very glad to be here.
And let me mention also, please speak into the microphone so the benefit of the people on Zoom can hear you.
David Browning. I serve as a deputy commissioner for the department. I've been in this role for a couple of years. Prior to that, I was the chief financial examiner for 12 years and dealt with auditing of insurance companies and financial analysis and licensing of companies over the years. So.
I'm Bob Williams, the Director of Life, Health, and Actuary for Commissioner Cheney. Been with the department 11 years. Before that, I was with Blue Cross Blue Shield for 20 years and United Healthcare for 5.
Thank you. Thank you, Mr. Chairman. I'm Mike Cheney. I'm the insurance commissioner. I've been commissioner for 18 years. Prior to that, I spent 8 years in the state Senate and 7 years in the House. And prior to that, I was a business person. And prior to that, my mother was a registrar for deaths and births in Lee County, Mississippi. So I became very familiar with the health departments. Been drug around by her in a 1949 Coupe Chevrolet. So I've been involved in healthcare indirectly for a long time, and also in insurance matters.
Good morning. I'm Jennifer Bryan. I am a family physician with Hattiesburg Clinic in Flowood. Have been there 2 years, and we were the first Hattiesburg clinic in the area. So very excited about that. I am immediate past president of the Mississippi State Medical Association. Have served in some capacity on that board for 11 or 12 years now. Former chairman of the board for 3 years there, particularly during COVID. Had to work a lot with the health department, the legislature there. I am an AMA or American Medical Association delegate and have served as chair of our delegation there nationally for many years, and most recently in June was elected to the AMA Council on Science and Public Health, where we are shepherding all kinds of issues and access to care, and insurance certainly play into that. I love policy and advocacy, so very excited to be here and working on this, and thank you for the appointment.
Good morning, Patrick Black. I'm an attorney for the Department of Insurance at Department of Finance and Administration for the State Health Plan. Prior to that, I've been an attorney with the state. Probably most relevant is attorney for the Division of Medicaid for 5 years, advising on counsel and policy issues.
Brian.
I'm Hob Brown. I'm in the state Senate. I represent District 7, which is portions of Lee, Monroe, and Itawamba County. I'm chair of the Senate Public Health and Welfare Committee.
Sam Creekmore, Mississippi House of Representatives from New Albany, Mississippi, Chair of Public Health.
And I'm Walter Michelle. I chair the Insurance Committee. My Senate district is Northeast Jackson, Madison, and Ridgeland and Gluckstadt.
Good morning. I'm Jerry Turner, and I represent the 18th District in Lee, Prentice, and in Northeast Mississippi. I've represented that district since 2004. I now serve as the House Chairman of Insurance, and I'm glad to be here with you today, and I look forward to serving with you and studying in this good committee. Thank you, Walter.
Okay, we have three members who are not able to be with us today. Dr. Stephen Chevalier was appointed by the Speaker of the House. And also two appointments to be made hopefully soon by the governor that have not been made is a president or chief executive officer of a health benefit plan. And the other person is to be an administrator for a hospital or ambulatory surgery care center located in Mississippi. Hopefully by our next meeting, the governor will be able to get around to making those two appointments, and we'll have a full committee. The legislation that passed called for all the appointments to be made by the end of July, and for the first meeting, it was pretty quick fuse to meet by August the 15th. And that's why we're here today. It also called for the chairman of the Insurance Committee in the Senate and the chairman of the Insurance Committee in the House to organize the first meeting. And I talked to Chairman Turner and discussed his chairing this committee. And he happened to have chaired a committee last summer and suggested that maybe since it was a Senate bill that the Senate chair the committee. And then I asked him to talk to Representative Creekmore as well. And he suggested Representative Creekmore would like to be vice chairman of the committee. I want to make sure everyone knows I am glad for anybody to chair this thing. The responsibilities would be to organize the meetings. We'll probably have 3 to 4 of them over the next 4 months. To line up the speakers, to get the audio system organized, send out the reminders. If anybody would like to nominate themselves or someone else to do that, I would love for that to take place now. But we need to elect a chairman and a vice chairman of the committee to organize the meetings for the next 4 months. Anybody any members of the committee want to nominate anybody? Chairman Turner.
I'm honored today to nominate my friend and counterpart, Senator Walter Michelle, to be the chairman of this study committee. He has well prepared himself for this. He has attended many legislative councils across the United States, and he's well read on this, and I feel he's the most qualified. And there might be someone else that's qualified, but he is qualified, and I want to nominate him as a chairman of our study committee. Thank you, Mr. Senator.
I second that nomination.
Okay, any other nominations, I hope? Okay, to the vote on that then, for Walter Michelle to chair the committee. All in favor, say aye.
Aye.
Any
Aye.
opposed? Okay, all right, thank you for the prestigious honor for the next 4 months. I look forward to working with y'all. All right, Chairman Turner, do you have a nomination for the vice chairman of the committee?
Thank you, Mr. Chairman. I do have a nomination. One of my colleagues from Northeast Mississippi, Mr. Sam Creekmore. He serves as the chairman of our House Public Health Committee. He's done an excellent job at that chair, and he has a heartfelt interest in the health care of our state. And so I want to nominate Sam Creekmore as our vice chairman.
Are there any other nominations for vice chairman of the committee? Representative Creekmore? No other nominations? All in favor of Representative Creekmore as vice chairman, say aye.
Aye.
Are there any opposed to that? Okay, thank you so much. We look forward to our next 4 months together. The legislation also called for approval for out of the House and Senate contingency funds for payment for per diems and mileage, and also for any expenses that are necessary to carry on these meetings over the next 4 months. So is there a motion that we do approve that, Representative Creekmore?
So moved.
Okay, there's a motion and a second. All in favor, say aye. Any opposed to that? Okay, thank you very much. This, of course, is our organizational meeting, but so the only thing I need to do was to get us started on the right foot. And then again, I'm going to rely on each member of the committee to please write down subjects that you would like to discuss over the next 3 or 4 months But the first was to kind of do a rear view mirror look at some important legislation that we've passed over the last few years. One bill that was passed during COVID was a telemedicine bill. And University Medical Center is going to present that, and they asked that they do that the next month. They had a conflict today, so that will be something we can look forward to at our next meeting. And the other was a bill we passed 2 years ago on the subject of prior authorization. And we'll brag a bit on the state of Mississippi in that the National Conference of Insurance Legislators has chosen our bill to be a national model bill, and it's going through the process right now on a national level. So what we would like today is that bill called for a portal to be set up and for everyone to sign up on the portal and be a part of the process. And it's run under the Commissioner Cheney's office. And so we've asked Commissioner Cheney please to give us an update today on where that process of the prioritization legislation stands. And I appreciate you doing that for us, Commissioner Cheney.
Thank you, Mr. Chairman. We'll go through these slides fairly quick, and it's my understanding that they will be posted on the website. So you'll have access to them if you're watching virtually. And I hope Luke can see these when we go through them. So Senate Bill number 2402 created a study committee. We've gone over that, and I'm going to kind of paraphrase some of these slides. And the study committee is tasked with reviewing the certificate of health benefit plans and health benefit insurers, including the areas of healthcare service, finance, and the delivery systems. And by the way, we put out a handout that will explain and define what things like managed care are. A lot of people say, what is a managed care plan? And it's simply a network of doctors and hospitals and other providers who agree to specific payment terms and quality standards. So that's a pretty open definition. And you have groups like PPOs, which operate in the North Mississippi. They're very prevalent, and they're more flexible in choosing a provider, but they cost more. And you have a higher cost for out-of-network providers. But that provides more access to doctors when insurance is not in a health plan. Insurer is not in the health plan. So the study committee will make a file and this is our charges, shall make and file a report of its findings and recommendations, including recommended legislation with the clerk of the House of Representatives no later than December 1 of 2025. And we'll work with the committee. If you've got suggestions that you want, we'll put it in our report. The presentation will focus on regulatory actions across the Mississippi Insurance Department and things that we do in regarding the certificates of managed care systems, the delivery of healthcare services, and the solvency of insurance carriers. So we've adopted 3 regulations. When you adopt a regulation, it's kind of burdensome in the fact that you have to put it out for comment. These have been adopted. They're in your packet. They're managed care plan network adequacy is in your packet if you want to look at it. It's pretty detailed. And you've also got the certification of the regulations and the minimum standards and utilization. So that's pretty self-evident. So the managed care network plans and managed care plan certification regulations work together to ensure that health benefit plans provide adequate coverage. And that MID has to review these plans and found that they meet the requirements. Now, let me just say that there's a lot going on in Washington right now with healthcare and healthcare plans. The 3 of us at the table have just returned from the National NAIC, National Association of Insurance Commissioners meeting in Minneapolis. We were informed by CMS there's still going to be some changes, especially on prior approval from the federal side. We don't know what they will be. We had some very productive meetings with CMS. Actually, we were the first meeting they had, and we had some sidebar conversations later in the evening concerning issues that affect our state, such as the number of people that will fall into the uninsured market, what will happen if Medicaid keeps going down, drawdown, how do we cover that, the ability to try to get a waiver to bring back the high-risk pool, which we're one of the few states that maintain the high-risk pool. So we've got some plans to work with the health department and the legislature on at their option of what they want to do to provide health care. And the reason I bring that up, and they're not in the slides, the average increase that we've had filed, we had to file these by noon yesterday, and we worked into the midnight and early in the morning coming back from Minneapolis. The average increase is 40.9% for all the plans on the ACA. I want to repeat that, 40.9%. That's what folks are going to be looking at next year. I got a call from the governor's office yesterday on what the subsidies are at the present time on the ACA, and rough calculations show those to be about $1.2 billion that the state will lose on subsidies, which will mean that people will go from paying $5 a month to $70 a month if they can afford that. And bottom line is we're probably going to have 200,000 more people at a minimum going into the uninsured market. And the reason I'm bringing that up is because it's going to affect prior approval, and it's going to affect the managed care network adequacy. It's going to affect the payors that pay out to hospitals and healthcare providers. And it's going to be a challenge for hospitals to stay in business if they don't have paying customers. And it's going to get worse unless we can figure out a way around it. So I just want to point that out before we get too far into the managed care side. So the certification route establishes a process for certifying managed care plans pursuant to the statutory requirements. This is all regulatory language, but we do that as now. So talking about networks, I want to say that we kind of saw in the future what was going on with networks. We worked with CMS and CIO, that's the Center for Insurance Information Oversight, to get ahead of the curve. And we basically adopted what the federal government uses for network adequacy. If you don't do that, then you can't sell an ACA plan, say in the Delta. You don't have a hospital between Greenville and Vicksburg. The closest hospital in that desert, you might say, healthcare desert, is Yazoo City, and it's on the brink of closing. If it does close, that will mean you will not have within a radius of 100 miles in the center, 50 miles from the center, any healthcare provider other than maybe an emergency clinic that shows up. So we've got our challenges cut out for us on the healthcare side on insurance. So I want to bring that out. So pursuant to the statutory law, the regulations do not apply to the Mississippi State Health Plan or to any managed care plan regulated by the Mississippi Division of Medicaid or any self-insured health plan. Those members of Massey are not included. I will point out that the state health plan does have to provide us with denials or approvals on prior approval. And I was asked the question yesterday by some interested parties on a Zoom meeting, what the state health plan does. And I'll just answer this for Patrick because I got it straight in an email. The state health plan will provide the numbers on prior approval that they get on outpatient care. Inpatient is still things like infusion and so forth is administered by someone other than the third-party administrator. So those numbers are not included, but we'll have all the numbers. Actually, we've got them with us today for last year. And we did not include it in the package simply because it's a long Excel spreadsheet, but you'll see in here that one company had 400,000 prior approval requests and their insured base is only about 40,000 people. So that's 10 requests per patient if you look at the average. The denials were very low, but it was just the fact that you had such a big increase. And I think it's going to be in the slides as we move forward. So I'm setting it up so I can go rather fast here. The purpose of the plans are pretty spelled out in the rules I mentioned to you. The adequacy regulation bulletin is 1405. It's in your packet. On April of this year, the department issued a bulletin 2025-3 entitled Network Adequacy Filing Instructions and how the providers are supposed to file. It's pretty simple. It's not complicated. They put them into a system called SERP, and that's a system for electronic filing and form filing. It's open to the public. If you've got a password, you can see rate increases from anything from property and casualty all the way up through healthcare plans. So we're not telling you anything. It's confidential. It's public knowledge. So since June 1 through a date of this past Friday, we've received 21 access plan filings. I don't think we've had any filings since last week, but we may have. Is it correct, Bob? So the certification regulations establishes the framework that MID uses to manage and certify managed care plans in the state, ensure that the plans meet the provisions of the act that was passed in 1995. Most of this is born as bad stew, if you look at it, but you got to know a little bit about it before you can make a decision. Additionally, by June 1 of every year, managed care entities have to submit to the commissioner's office in an electronic format such as Excel. That is really readily usable by the department. A complete list effective for January 1 of that calendar year of the names of the participating providers. Each participating provider's closely affiliated type is provided for in Rule 1405, which we put in your packet, and the complete practice location address for each provider and the contact information for each participating provider. Based on this information, we'll send all of this around to all the department heads and look at what we got to do to get everybody certified. So prior authorization, during the session, we pretty well covered most of this, but I want to get out into, for time's sake, into some of the agents regulations. This has been an issue with us where agents which out of state would churn the people's policies so they can get a commission, and you never can catch them. And we've asked the feds to try to give us those names so we can go after them. But the fraud and in these issues is just, it's horrendous. It's horrible. So we've got some codes, the last part of this, 83.5, 935, and one of the rules that promulgates on holding company acts require a health insurer issuer to submit an annual report to MID providing aggregate data and information regarding the issue's prior authorization practices and experiences for the provider year. And that gives you a kind of a snapshot of what each plan is doing. So most of this is just, it's run of the mill. It's in the slides. It's the number of prior authorization requests denied, the number of appeals received, and the number of adverse determinations reversed on appeal. And I will say this, when people appeal, they normally win. And when they call us, that data's not in here, we're going to start putting it in. We can usually get an approval. But insurance companies sometimes use the appeal process just to delay and not cover somebody that's entitled to a coverage. And I as a sidebar, I want to add that the legislature was kind enough last year to pass a bill, and the governor signed it, that said if a resident in Mississippi had a plan issued in Alabama or Tennessee and they had paid a premium for it, they were entitled to those benefits. We had a Blue Cross guy that had a plan out of Texas. His wife's a retired state employee with Blue Cross on the state side. And Blue Cross Association would not approve him for a treatment for 5 weeks. And we got involved, and Bob and my staff, which was amazing, got it done in 3 days, working with UMMC. So that bill just said that that man was entitled to the benefits, and we just bypassed the state here and went straight to the Texas Blue Cross, and they said it's covered, get it done. The guy it's a form of cancer where he needed treatment. So the quality of his life diminished over that 5 weeks waiting on that approval. That's a big deal. The rest of this is just run of the mill, the healthcare services, the 10 healthcare services that were most frequently denied as a result of post-service utilization reviews. And I will tell you that most of this is going to come into gene therapy and on the healthcare side. We're still trying to figure out what we're going to do about prior approval on drugs. We're not qualified to be doing this, but we'll figure it out. So you need to understand that when a doctor will prescribe a drug that may cost, well, like a GLP-1 that costs $1,000, and you can buy it in the open market for $299. Y'all know what I'm talking about. And the plan denies the GLP-1. How do we fit into this? Is it covered? And is it in the formulary with the companies? And they change the formularies. We do not regulate. I want to make it clear. We do not regulate Medicare or Medicare Advantage plans. And they're the big abusers of most of these things. So we're working through these areas. So let's get into the total. This is what a report summary looks like, the number of PAs required, like on Centene. We'll just use them as an example without going too deep. They had 171,000 requests. The total number of requests denied were 39,000. The total number of appeals received, 2,886. And out of those that had adverse, it's about a 40% rate if you want to look at it. You can see that were reversed were 1,475. The total number of prior approval requests and the prior approval requests not submitted electronically were 43,000. And some of those are included in people filing a complaint reform and submitting them to the Department of Insurance. And you can go on and read across this. I will tell you, when you look at the percents, the percent on denial post-service is 57% that's held up. So the numbers pretty well, we know that 40% of people that appeal are going to probably be approved. Carrying it on out, you can see the Medicaid side. We do have those data in here, although we don't regulate them. This is something, if you're on the Medicaid committee, you might want to look at the total number of requests, the denials, and et cetera. That's under the managed care plans on the Department of Medicaid. And this is helpful for those people that serve on those committees. Blue Cross Blue Shield. Most of you, if you're in the know on healthcare, are going to say, wait a minute, they only had 8,799 prior approval requests. This is on individual policies. We don't have the data in here for the group plans because they didn't give it to us. So just want to make you aware of that. We're trying to sort through how they got around the law, and we'll figure it out. We were working on it yesterday. Bob and I were. David was fighting a battle for us in Minneapolis. He got in at midnight last night. So you do know we work. So University of Mississippi, United Healthcare had 45,000 denials. We have very few problems with them on the denial request. They work pretty good. Molina, you've got two divisions of Molina. You've got Molina Healthcare of Mississippi, and you got Molina Clinical Services, which handles basically Medicaid. So Representative Creekmore may want to see that number's over 400,000, but that's just how they manage the Medicaid. They deny or they ask for prior approval. Cigna, let's talk about risk-based capital for a minute. We were asked to look at risk-based capital. Risk-based capital just is simply, we didn't put it in the definitions, but it's the amount of capitals at risk based upon the liabilities that a company has. The floor, the minimum a company can have before we call them in for an examination is 300%. Actually, we start looking at them if the risk-based capital is 400%. So that just says you got to have $4 for every dollar you owe in liability. And that's the simplest way to explain it. So one of our domestic carriers has a risk-based capital. If the higher it is, it means the more money they have, has a risk-based capital that exceeds $1,500. So they've got $1,500 in risk-based capital for every dollar of liability they got. And we don't regulate the risk-based capital unless it falls below the floor. If it's above that, we have no say-so at all. They can do what they want to. But that simply says that company could never sell a policy and put the money in the bank and probably make bukus forever without ever issuing a policy. And we don't control them because they're a mutual company. The number of people covered lives for the 2024 markets, an interesting slide. The individual over here, where you start at the top, I don't have a pointer on this thing, but if you have Blue Cross Blue Shield has 26,000 individual lives, that would fall under prior approval. Small groups fall under to some limited degree. The rest of them are ERISA plans, and we don't regulate ERISA plans. That may change, but So far, Tennessee's the only state I know that's regulating ERISA plans. Those are self-insured plans. So if you got a double star by your name up here, you're in the federal marketplace. And why that's important is if you go over, and let's just take Ambetter or Magnolia. They had 190,000 people on their rolls in 2024. 2025, it approaches almost 300,000. They're projected with the new rate increases to drop to 64,000 people. So you got to say, where do those 250,000 people go? If they're not in the ACA, they may buy an individual policy. The rules have tightened up where the Internal Revenue Service will audit you if you falsify your income. They're going to become the uninsured population that goes to the emergency room to get health care, uncompensated health care. And what that's going to do is put more pressure on the hospitals. When that pressure comes and the hospitals don't have money, you're looking at a potential train wreck. And what we're trying to do is look to the future as a regulator to see what we need to be doing on the insurance side. So just pointing that out. Any questions on this slide? I'd be happy to take any from the committee. When you look on the top part, Blue Cross Blue Shield of Mississippi, the uninsured plans will include the state health plan, which is about 184,000 to be exact. They're included in that number. They're not subject to the prior approval regulations except for reporting purposes. So when you look at it and you add all the numbers up, you will see that Blue Cross Blue Shield, either as a corporation or a mutual company or as a TPA, controls over about 80% of the market. When you hear that number, but when you look at the number of individual policies, they're very small. And while this slide is so important, if you look on here outside of the federal marketplace, the people that issue individual policies, if you want an individual policy in Mississippi, you got to go to Blue Cross. And they're good. I will tell you, they're really good about providing policies. They're not cheap, but they're good. There's good coverage. And I'm just saying, you don't have a lot of choices in Mississippi. We had to give Molina to keep them from pulling out of the state, which they cover a lot of the Delta. I agreed Monday with them in phone calls and conversations, and we had the federal government there with us listening to give them the rate increase they needed to stay in the market, which was 60%. But that will mean the number of lives they cover will go down, but at least we got some coverage for those people in the, what I call the donut hole, from 100% of the property level to $250. Instead of paying $5 for a policy, they'll pay about $60. But at least we got coverage for those people in the Delta. The rest of this is by premium share. So this is a really interesting slide. Ambetter or Centene is the biggest carrier or the largest premium-based company based in Mississippi that sell it. They are not domiciled here, but they're a big marketer. Any questions on this? So gentlemen and ladies and gentlemen of the committee, and Mr. Chairman, that's our presentation. Be happy to take questions.
I do have a question on page 17. All the information on the prior authorization, which is the summary of the denials and those denials that were reversed on appeal and the most frequently denied prior authorizations, is that to be presented at the end of every calendar year? I can't recall what the legislation did on that.
It is presented, and I'll be happy to give you, this is a sheet for 2025. I've got one. We may have two to give you and the vice chair a copy of. This is really good information. It's on the website, and some of that is also in your packet here.
Could you please provide that to us at the end of the year prior to the 26th session? Would you have a calendar year
David,
information by then?
The information is due June 1st of each year. So what we have currently is what we just received in June. The next report will be due June 1st of 2026.
Thank you. Hey, anyone questions, please? Thank you, Commissioner. Thank you so much. I appreciate that. Mr. Cheney mentioned GLP-1 drugs, which we know is anti-obesity medication. And Commissioner Cheney is on the board of the state health plan. Patrick is on the board of the state health plan. Chairman Turner and I are ex officio members on the oversight committee and the two chairmen of appropriations. And we hear that term anti-obesity come up a lot now on our state health plan. We know it's important. It's a very important topic in Congress on Medicaid and Medicare plans. So we're pleased to have today, would you, Paula? Paula, would you please come forward? Paula Whiteley. Just, yeah, right there, be great. We can get the microphone. That'd be wonderful. Paula is the regional account manager with Novo Nordisk, which is a leader in this industry. And she has a presentation that's going to be one of her counterparts through Zoom. And we appreciate you being with us today, Paula. Please introduce your presenter.
Thank you, Mr. Chairman. Make sure, is this on? No. Okay, perfect. Thank you so much for the invitation and the opportunity, and good morning to the committee members. Like Senator Michelle said, I am Paula Watley. I'm a regional account manager with Novo Nordisk, and also a nurse by training and a lifelong resident of Mississippi. So I truly appreciate this committee and your dedication to making our state healthier. So I have the pleasure of introducing Dr. Courtney Walker, and he is the medical account director for managed markets with Novo Nordisk. And he serves in Mississippi, North Texas, Louisiana, and Arkansas. And in his current role, he works with health plans, state government, and employers in providing clinical support, and engages and implements medical account strategies on behalf of Novo Nordisk for priority managed markets accounts. So in Dr. Walker's previous role with Novo Nordisk, he worked with large employers such as BP, Southwest Airlines, AT&T, U.S. Steel, who are attentive to the clinical crisis of obesity and diabetes in their employees. His aim was to assist these companies with the improvement of their employees' health via proper medical management. Dr. Walker is a proud graduate of Texas Southern University College of Pharmacy and Health Sciences in Houston, Texas. Upon completion of his Doctor of Pharmacy, Dr. Walker completed a managed care pharmacy practice residency at Humana Inc. in Louisville, Kentucky, and the University of Kentucky's College of Pharmacy in Lexington, Kentucky. He has completed more than 22 years of pharmaceutical industry experience and has given hundreds of clinical presentations across the country. Dr. Walker is active in his community by serving as an elder in his local church and speaking at various diabetes, obesity-related events to improve clinical awareness. He was also a moderator for the 2018 Congressional Black Caucus in Washington, D.C., leading a discussion on diabetes awareness in the African-American community. He is a proud husband of Jocelyn, a physical therapist, and father to 4 great kids, and he currently resides in Texas. And I dare say he's an avid Dallas Cowboys fan. I don't know if that helps or hurts, but that's our introduction to Dr. Walker. And thank you, Dr. Walker, for being present and presenting to us.
Thank you so much, Paula, and it's a pleasure to be here. I grew up in Arkansas, and there's a lot of Walkers in Tupelo, Mississippi, and so I spent a lot of my summers in Tupelo as a kid. So it's certainly an honor to be here today. I'll go ahead and get started with my time. 3 things that I'd like to share with you guys on today is that 3 things for us to consider is that cardiometabolic disease, which basically defines a group of diseases that over time increase multiple comorbidities, and just it's basically a firestorm of other diseases that can be impacted that ultimately can lead to heart attack and stroke. Secondly, managing cardiometabolic disease requires a comprehensive, detailed approach. And thirdly, GLP-1, specifically semaglutide, in this example, is a molecule that can play a role in reducing negative impact of cardiometabolic disease and can have the impact that cardiometabolic disease can have on patients and improve their health and reduce the costly disease exacerbations. And when you take in consideration, we're going to talk about the fact that heart disease is the leading cause of death in the United States. Then you have other obesity-related cardiovascular deaths that are also increasing as well. So when you look at heart disease, it's number 1. You also look in the top 10, you have diabetes, you have stroke, you have kidney disease, all of those certainly working in concert. And what we know is that from 1999 until 2020, there's been a threefold increase in obesity-related age-adjusted cardiovascular death. So we know that that has increased. And unfortunately, and certainly I've lived my whole life in the South, certainly from Texas to Arkansas to Mississippi. We know how to fry everything. There was a sports announcer here in Dallas that calls it the chicken fried nation. So certainly that has certainly had an impact on our overall health. And Mississippi actually ranks number 2 currently in obesity and in diabetes. So when you think about that, certainly there's significant impact. And the scary thing is across our country that if nothing changes by 2030, 50% of our society will be either overweight or obese. And what we do know from COVID-19 is that 78% of those who were hospitalized, who were put on ventilators, and who died were actually either overweight or obese during the pandemic that we went through 5 years ago. So what I really want to talk about is the impact of cardiometabolic disease and how specifically semaglutide, and this is not a presentation to stress so much the greatness of semaglutide, but really talk about we're in a situation where cardiometabolic disease is significant in its impact. And our research at Novo Nordisk is really focused on how can we provide solutions to the issue of cardiometabolic disease. And so there are multiple approved products with semaglutide as the active ingredient, allowing for timely delivery to affect this disease condition of cardiometabolic disease. And so we have the everyday oral, the every week injectable that can be given. And this is how the molecule has been designed to address cardiometabolic disease. And when you think about chronic disease and cardiometabolic disease, you have to take in consideration the foundation is obesity, which is considered a gateway disease to so many others. That from obesity, you have increase in what's called insulin resistance that can lead to type 2 diabetes, ultimately to lead to cardiovascular disease, which then could lead to stroke, heart attack, peripheral arterial disease, kidney disease, liver disease, and then heart disease through heart failure disease as well. So you really, to be able to manage that, you need a multifactorial, holistic approach that is person-centric, that is focused on the patient to actually work to reduce the impact of these overall diseases, which then can lead to so many negative health outcomes. There was a doctor in San Antonio that came up with this concept called the ominous octet. And what he did was he looked at 8 organ systems in the body, and he looked at the fact that GLP-1s actually work to help in all of those different 8 organ systems. And certainly I heard the previous speaker in the meeting talk about GLP-1s, and this is not a conversation, obviously, just in the great state of Mississippi, but this is all over the country, where the impact of GLP-1s has been talked about, and really wise, because when the pandemic occurred and all of us were at home, we became hip to the reality that we're at like 42-43% obesity in the United States of America. And with that, you have a cavalcade of so many diseases, and these diseases affect these different organ systems. So from a GLP-1 perspective, semaglutide is the only product that has an indication in kidney disease and chronic kidney disease to be able to lower the risk of the negative outcomes in kidney disease. We have a submission for the liver that is to be released by the FDA on next week, because you see here in the liver, you can see the reduction in inflammation in the liver, and that can work to bring about healing. Then there's the impact of the reduction of blood pressure, the reduction in appetite, platelets get better, the intestines get better from a gastrointestinal perspective, where you have a slowing of gastric emptying, which leads to the effect in reducing weight. And that we know 5% weight loss is what's considered clinically meaningful, and up to 10 to 15%, we're able to see diabetes reversal, health improve, osteoarthritis improvement, pancreas, the function of the pancreas improve, and then working to ensure that Insulin can do its job to help sugar, glucose get inside of our cells to give us the energy we need. And then overall, what's called the cardioprotective effect, the protection of the heart, which is so very important, reducing heart attacks and strokes. So what is the impact of obesity we know on risk and prevalence of cardiometabolic disease? We know that obesity affects 86% of patients with type 2 diabetes, 81% of patients with liver disease, which is called MASH. We know that 70% of patients with chronic kidney disease are impacted by being overweight or obese. We know that obesity accounts for 65 to 75% of cases of primary high blood pressure. We know that 11 to 14% of the cases of heart failure are affected by obesity, and obesity affects greater than 80% of patients with heart disease, and leading to 18 to 44% of patients with stroke. So all of these areas are areas that, if unaddressed, certainly can lead to so many negative health outcomes. And so certainly that's what we have to think about. And from a cardiovascular perspective, you see from appetite, helping people to lose weight, cardiovascular, reducing blood pressure, improving the lipid profile, reducing inflammation, which can lead to so many other problems, glucose regulation, so that diabetes sees improvements. And from a gastric effect perspective, really helping from a stomach perspective, reducing in gastric emptying, reducing the amount of food eaten. And certainly this is within the armamentarium of what can be used to affect the obesity problem with patients who are suffering from it. And then, as I stated earlier, in January of this year, we had the approval for semaglutide for chronic kidney disease, because we saw that there was a decrease in the risk of worsening of kidney function. So real quickly, I'm going to go through just quickly the disease states. We see in diabetes, we see significantly that we can see an improvement in type 2 diabetes. We've seen semaglutide studied in a number of different studies in a number of different patients. And from a tolerability standpoint, that we're talking about under 10% in terms of rate of discontinuation. And that is, we know that there's some individuals that certainly can't tolerate. And so as a pharmacist, what we have to do is make sure we do a great job, and physicians as well, in counseling patients in terms of how to titrate, meaning to start off low and really watch what their diet entails. Because if you eat greasy and fatty foods as you're taking GLP-1, certainly you'll feel worse. And so that's certainly something to be aware of. And but we know that well-established safety data has been seen in diabetes. We know that 80% of patients with type 2 diabetes achieve an A1C less than 7 with oral and injectable semaglutide. And what's significant there is when you get your A1C less than 7, you reduce the likelihood of microvascular complications, that's kidney and eye disease, by 34%. That was seen way back in the DCCT trial, that getting your A1C. So whenever I talk to family members who have type 2 diabetes and they say, hey, what should I be aiming for? I always talk to them, get that A1C less than 7, because when you do, you're going to reduce the risk of microvascular complications. And that's where it ends up costing the state, costing the health plans, costing significant once you get to these microvascular complications, and then ultimately macrovascular complications, which are leading to amputation, leading to cardiovascular disease, which are extremely costly, leading to presenteeism issues and absenteeism issues for workers, where they can't go do their jobs because of those specific problems. And we know that getting your sugar under control is has been seen, and it's been early and sustained for 104 weeks in patients who take at least 1 milligram of semaglutide, and that's the Ozempic. So that is pretty significant as well. And you have the injectable option, you have the oral option that can be taken. And so certainly that's something to think about as well. From an obesity standpoint, we saw up to 17% reduction in weight. And that's in patients who were taking the 2.4 milligrams. And we know that weight loss has been sustained over 2 years in over 90% of patients. So that's pretty significant. in terms of in terms of 90 kilograms of individuals over 2 years. And we know that 4 and 5 of those on semaglutide achieve a 10% body reduction of weight. And so when you talk about 10% reduction, you're headed in the direction of really impacting their health in a positive way. 1 in 3 those on semaglutide had greater than 20% body weight reduction, and so that's pretty significant. Then look at all the other effects that we saw: blood pressure reduction, A1C improvement, waist circumference. The two things the physicians certainly look at in terms of overall health and quality of life is BMI reduction, the body mass index reduction, and/or waist circumference reduction, getting males and females down to a healthy waist circumference. And then the most impactful is that C-reactive protein, which is an indicator of inflammation. And we know the internal inflammation can lead to so many problems in the liver, in the cardiovascular system. During COVID, we had a presentation that we did, a conversation we had on the impact of diabetes, obesity, and COVID-19, and the fact that there was a cytokine inflammatory cascade that really so many physicians talked about being as a part of why that there were so many deaths, because of the impact of this cytokine storm. And really inflammation, internal inflammation, was the big impact. And that goes back to that CDC statistic I mentioned earlier, that 78% of those who died, were put on ventilators or hospitalized, were either overweight or obese, and obesity is thought to be an inflammatory condition internally. So certainly needing a medication to help to reduce that is certainly impactful. So what we know is semaglutide can lower the energy intake. Energy intake is the act of eating, and it reduces hunger, increases you feeling satisfied, because it actually attaches to the satiety centers of the brain, reducing your cravings and improving your control of eating. Then from a cardiovascular disease perspective, we looked at it in type 2 diabetes patients with cardiovascular disease, and we saw a 26% reduction in stroke, heart attack, and death associated with those individuals. And then we also looked at and saw a 24% reduction in the oral, those who were taking the oral medication. We also took a look at it in patients who did not have diabetes, they just had obesity. We saw a 20% reduction in heart attack, stroke, and cardiovascular death. This is included in the label. And when you think about that overall benefit, and remember, as I mentioned, the cardiometabolic disease is about how can we lessen the likelihood of heart attack and stroke. And so taking that in consideration, semaglutide is one of the only GLP-1s that has that indication for reducing cardiovascular disease in that way. And so that's extremely important. So first line GLP-1 with proven cardiovascular benefits. And then from a kidney perspective, we know that 1 in 3 patients with type 2 diabetes have chronic kidney disease. And we saw a 24% reduction in negative kidney outcomes or kidney disease. And with that, we know that there's a strong relationship between cardiovascular events, where we saw 18% reduction, and we saw a 29% reduction in cardiovascular death associated those with chronic kidney disease. So, and all-cause mortality decreased by 20% as well. And we saw specifically also a reduction in kidney decline better than finerenone, which is a current drug that is actually on the market. We also have a couple real world studies that I'd like to talk about now before I answer any questions. And basically what these real world studies do is they say, way after we kind of have published data, we've been watching patients and we look at them in the Komodo database, and this is 330 million potential lives that we look at in over 150 plans. And basically what we looked at is we looked at over a certain time period that they were on semaglutide at 2.4 milligrams, And we wanted to be able to see if we would see a replication of what we saw in the SELECT trial, where we saw the 20% reduction. And what we did, we actually saw that. We saw 57% relative risk reduction in MACE-related events, and that's stroke, that's heart attacks, and that's all-cause death. And then we saw in that, and then we looked at it from a revised MACE-5, where we looked at 5 things. We looked at heart attack, stroke, being hospitalized for heart failure, all-cause death, and then coronary revascularization. We saw a 45% relative risk reduction as well. And then lastly, from a cost perspective, we did this study in atherosclerotic cardiovascular disease, where we looked at real-world medical costs and healthcare utilization with semaglutide at 2.4 milligrams. And we looked at this over a year's time, over a year time period. And we looked at the patients a year before we watched them and a year afterwards. And what we actually found was that mean total costs were $4,639 less for those on semaglutide 2.4 milligrams compared to those who did not use it. And then we saw the greatest benefit actually in inpatient costs, where there was a 60% lower inpatient costs in patients on semaglutide than those who weren't on the medication. And so that was pretty significant as well. I'd like to also highlight that the state of Mississippi has been phenomenal from a Medicaid perspective as of 2023, paying for anti-obesity medications. And Mississippi has also been phenomenal at sharing that data. And they only saw 2.4% utilization of anti-obesity medications being used, 2.4%. And they actually had the updated data as of June 2025. And so certainly something that, we often have questions regarding utilization and what we see. And we've always said it's between 2 and 5%, but there are those who have huge concerns about the numbers going up. And unfortunately, that is due to the great need that we have. But the data in Mississippi has been phenomenal from an anti-obesity medication perspective since 2023, when you guys began to cover from a Medicaid perspective semaglutide at 2.4 milligrams. So I'm gonna go ahead and stop at this time and answer any questions, but thank you so much for the opportunity to be able to share this information. I'll leave the slides up just for a little bit to see if there's anything you'd like me to go back and kind of talk about, but I'd love to answer any questions at this time.
Questions?
Chairman Michelle, can I ask a question?
Please do, Dr. Lamb.
I did want to say there's some recent studies with GLP-1s where they also can have an effect on alcoholism and alcohol intake. Dr. Walker, what have you seen about the role of GLP-1s with reducing alcohol consumption in those that have issues with alcoholism?
Absolutely. We actually have some data that we are looking at in terms of alcohol use disorder. And we noticed that there has been a decrease in the use of alcohol in those who are on GLP-1s. And so certainly they're still kind of trying to figure out the exact mechanism. We think it has to do with the satiety center somewhere in the brain, where that certainly is being an effect, but that is something that we're looking at. So it's AUD, alcohol use disorder, that specifically it's kind of characterized as, but that is something that we've seen, because what they've noticed is that those who've been taking the medication, there's been an increase in GLP-1 utilization. And I go all the way back. I actually was with Eli Lilly back when exenatide was launched. So I go back to the days of the Gila Monster saliva that, that Bida was sort of known for at that time. They noticed that, GLP-1 utilization certainly had a relationship with, lessening desire to drink alcohol. And so that's what we're looking at specifically with semaglutide's possible benefit in alcohol use disorder. So that's certainly something that's in our pipeline, and certainly something that we're talking about and sharing, but this could potentially be an additional benefit for utilizing the medication.
And one other thing with fatty liver disease or MASH or whatever we'd like to call it, we have seen with GLP-1s there is regression in the disease process, right? In the fatty liver of the liver. which, if not treated, progresses to cirrhosis.
Absolutely. And thank you so much for bringing that up. So we submitted to the FDA, and I'm sure you were aware of this earlier this year. We're we're excited. We're supposed to hear next week. So 5 days, August 19th is the PDUFA date for the MASH indication. And so the MASH indication, we had the Essence trial, which was published, and we can certainly provide that data to you guys. But we looked at 72 weeks. We did biopsies of patients before and at the end of the study, and they had an F2, F3 designation where they weren't cirrhotic yet. They didn't have cirrhosis of the liver. But to your point, the liver is a very resilient organ that certainly can heal itself if you don't have alcoholism, if you're not drinking, if you're having a healthy diet. And we saw pretty significant reduction, in terms of what's called resolution of MASH and no worsening of liver fibrosis, and then improvement in liver fibrosis and no worsening of MASH, which actually exceeded the current molecule. It certainly wasn't a head-to-head study with resmetirom, but what we saw is a 62.9% of patients achieved that resolution of MASH with no worsening of liver fibrosis, compared to only 34.1% on placebo. And then the improvement in liver fibrosis and no worsening of MASH was at 37%, compared to 22.5% on placebo. So when you think about that, that's again the cardiometabolic story that we're trying to formulate. It's not so much about, it's really about the data, really about the science, and really saying, hey, this could possibly be a certain help, certainly in patients who are suffering with some of these diseases.
And so certainly there's significant use of this medication outside of simply diabetes treatment.
Yes, it is. Outside of diabetes, obviously obesity. We have the indication, as I mentioned, for chronic kidney disease. We have, there's a doctor in Louisiana. I cover Louisiana as well. And, he has seen significant impact in heart failure patients. And so we have the heart failure data that we also have as well, where we've seen improvement in heart failure. So yeah, across the board. And that's really why there's this messaging. If you think about it, 20 years ago, there was a concept of polypharmacy where, it was actually negative if you looked at the molecule and you thought of all the different typical opportunities you could possibly have to utilize it. But in this particular instance, it's the cardiometabolic approach where we're saying, due to the reduction in inflammation and reduction of weight, in addition to weight, you see a significant impact on reducing the impact of some of these negative diseases and improving health outcomes.
Thank you. Good presentation.
Thank you, sir.
Anyone else? Thank you so much, Dr. Walker, for your overview on the subject. We appreciate all the knowledge you brought to us today. Thank you so much.
Thank you, sir. Thank you, guys.
I want to ask Patrick a quick question. Patrick, in the board meetings, did the state health plan give formal approval for sleep apnea on the GLP-1 drugs at the last meeting? I can't remember if it came to a vote. And what other heart disease and what else does it cover?
We cover diabetes, cardiovascular disease, and sleep apnea.
Right. Okay. Thank you so much. Okay. I want to call on Dr. Jennifer Bryan, a member of the committee, to give us a practical summary of what she sees in her daily medical practice and here in Mississippi on this subject.
Thank you. I appreciate that. In my real job as a family doctor, I spend a lot of time drilling down this kind of scientific stuff, which is excellence, into real talk about what this really means for us as Mississippians. And as you heard our speaker say, we are number 2 right now, the most obese state in the nation. So it's mission critical in dealing with the obesity problem. And we can step back and say all day long, why don't you exercise more and eat less? But we also know that society has evolved. When you look at the big picture, we sit at desks and at computer screens. We're not raising barns like we were a century ago. We're not burning calories the way we were. We're not growing our own food, and we're buying in mass production. And there's lots of other reasons that factor into. So instead of pointing the finger at the patient all of the time and saying, why don't you? We finally have something that works. And not only does it work to help people, but it does do all of these things. And it's, by the way, this is a class of drugs. There are many drugs that we should look at that some are FDA approved for this, and some are FDA approved for that, and some are approved for the same thing. And my guess is that they've just done studies in those areas, but they all have very good effects of the things that are being talked about here, some better than others. At the bedside, we have Mississippians that are desperate for help. We know that these medications are generally $1,000 at retail. And if their plan covers some, they can get it reasonably. But if their plan does not cover it, Mississippians' next choice is to pay $499, which we are grateful to the industry for coming down for that. That has helped a category of people who can pay $500 a month for the medication. But still, the average Mississippian cannot afford $500 a month. And so it cycles on. So we want to help them. They want the help. They've seen the videos on social media. They see their friends doing it. Finally, something can help me. And it does go into, we see people that have alcohol use disorder and so on. So these are very real things that are being looked at, and this is a wonderful class of drugs. What I would say is what you just talked about is really important. The cost is something that we need to consider. We can't bankrupt plans and say, this is a miracle, we want it for everybody. But a targeted approach covering FDA-approved high-risk people like those who have heart disease and sleep apnea, kidney disease, these underlying conditions, you're going to save, and there's no hard data yet to say what I'm saying is 100% accurate, but you can imagine in 20 years, the recouped expense, right? And then this thing goes off of retail into generic as over the lifetime. So sometime down the road, it becomes generic and affordable for everybody, but it's a long way down the road. So if we've got a Mississippian who is going to live for the next 40 years, you are presumably preventing many hospitalizations, surgeries. Obesity-associated cancer is something a lot of people do not realize. Obesity is a huge driver of cancer. All of the chemo, the radiation, all of the things, just having something to combat obesity helps prevent downstream expense. But in the short term, there's not a lot of data in the first 2 years that this pays for itself, which is why I would say we look at targeting it. I mean, I would love for everybody to have it, but it's a really good start in decreasing long-term expense. And I think that data is forthcoming, and we can rely on that as we make recommendations in the coming years. So I would urge the committee to, all of the science here is good. Big picture, we're an obese population with a lot of complications, and we want our dollar to go farther. So targeting those complex patients and urging insurers to cover those who already have stumbled into these high-risk diseases, I think can make a big impact on the health of our state as well as what we spend. And I'm happy to answer any questions, but this is I mean, every patient that walks into my clinic, this is the conversation we have about how do I get it? And I say, do you have $500? Because we're thinking short term, this expense right in front of us, but we can urge payers to think longer term. And I think that data is evolving.
I would love to see some serious discussion between some of the companies and our state health plan to see if they would do a trial and track those results like you're talking about. Certainly with this many obese people that live in Mississippi, we'd have no trouble coming up with 500,000 people with a BMI over 40% or so that they could really track great results. And
well, and I mean, I'm not on the negotiation side, but we certainly have a patient population that would use these products. And if you bring a patient panel that all are obese, and what I find myself doing practically is, let's get you a sleep study because you probably have sleep apnea. Not because they're complaining that I think they have it, but I know I can get an indication because I want them to lose 60 pounds. So we do need to lean in, and it's almost a leap of faith a little, that it makes common sense that if we take care of these risk factors on the front end, the downstream expenses there, because until time goes by, it's just not going to be as available as we would like to do that look back. We've got a mission critical with obesity in our state.
question?
Dr. Bryan, I know this is early and you don't have as much data as you'd like to have at this point to talk about this, but have y'all given any consideration to medication versus surgery?
You know, I am certain that the industry has looked at it, and the surgery these days, the risk of having weight loss surgery is about like having your gallbladder out. So when patients ask me if I'm for it, I say yes. I'm for anything generally safe that combats obesity. And I will be happy to look that up and get see what data is out there and bring it to the next meeting. But that one is definitely on the table and also difficult to get covered. patients don't have a lot of good options.
Do you think there might be any data that you might be able to acquire that would give us an idea of what the long-term cost would be on the patient and how much quicker you could put it back into the workforce and have a healthier population quicker?
I think you bring up an excellent point, and I will go and find whatever data, good data is out there and bring it to you. I don't know what is out there on that specific point. I think the reason the medication comes up so much is because weight loss surgery is not indicated to treat diabetes, but these medications are, and so many obese patients all have diabetes that it's two birds with one stone. You know, you need a medicine for diabetes. I can fix your sugar and your obesity, but certainly if you go lose a lot of weight with weight loss surgery, you can get rid of the diabetes as well. So I'll look at that specifically to compare those meaningful points you just talked about.
Well, I sure would appreciate that, and I think it'd be meaningful to the committee to hear that as well. Thank you.
I think it's an excellent point. Thank you.
Chairman Michelle, can I make a comment?
Sir, Dr. Lampton.
Following up on what Jennifer said, I really like her proposal for the insurance companies to look at some targeted use in some of the patients that have morbid obesity, and especially that have some comorbid disease processes like MASH, fatty liver disease, sleep apnea. Of course, we're already looking at sleep apnea, and even possibly some targeted use in alcohol use disorder. I do think, though, I was talking with several of my patients about bariatric surgery who did not qualify for a GLP-1, and a lot of them have a lot of, even though if they didn't have any other disease processes, the bariatric surgery would not be an extraordinary risk. Oftentimes, the ones that are pursuing bariatric surgery have kidney disease, diabetes, hypertension, and they have a lot of what physicians call comorbidities, which are they're complex medical patients. And those patients become very high risk for bariatric surgery. In fact, very high risk for any surgery. And certainly the GLP-1s are going to be a much safer option for the complicated medical patient rather than bariatric surgery.
I totally agree with that.
Dr. Bryan, once a patient who's obese and takes the GLP-1s and then they reach their target weight, what is this? And they're weaned off the GLP-1s. Is there data showing that they're able to maintain that going forward?
Not speaking on behalf of the industry, but what I have seen in the real world is that's where my art of medicine comes into play. And I have seen patients that certainly if they stop the thing that is helping them, you can expect rebound. Now it's slower because they've learned a new lifestyle presumably, and some won't. And you can let them try, but if they begin to hit problems, they can restart it. You can put them on an every other week regimen. You can reduce the dose down to a negligible dose, but it's not unlike taping. I have high blood pressure, so I take high blood pressure medicine my whole life, or I have diabetes. I'm going to be on Ozempic for the rest of my life because I have diabetes. Morbid obesity and obesity are chronic conditions. So we usually end up treating them chronically, but certainly you want to give somebody that shot or that chance.
Thank you.
But I think the generic piece is what's important. The expense goes down once it becomes generic. We're talking about a finite period of time, but the other thing we're thinking about as this committee, this is not the first drug like this, right? And there are gene therapies right now that are $3 million a dose. And as we evolve with AI and new medications, I don't know what the answer is to who gets the medicine and who doesn't, or how we implement it. We've got big challenges ahead on wonderful innovations and who's paying.
Thank you so much for your knowledge on the issue as well. This sounds like a subject we may want to continue to study during our next 3 or 4 months. So when we meet, Senator Bryan has a comment on general issues.
Well, but before we left, I was just going to make the point that one of the constant concerns I have is looking at things comprehensively, and whatever changes we make about managed care has implications elsewhere. One example is that I am getting to the point of apoplexy about what I call the 70 counties in the state or thereabouts that are not in the Memphis metropolitan area, not in the Jackson metropolitan area, not on the Gulf Coast, and don't have located in them a major comprehensive university. And those 70 counties are in trouble. All the trend lines are wrong for them. And one of the concerns is part of this is healthcare. And there is a trend to have less and less and less healthcare in rural areas and concentrated all in a few places. And it is done in the name of efficiency and on and on and on and on. But it's devastating for rural areas. The example I give of how the world can be is that there's a federal court in Aberdeen. In fact, the bankruptcy court for the whole northern half of the state's headquartered in Aberdeen. And you wouldn't think of putting that in Aberdeen necessarily, but it works just fine. If the federal judges show up to hold court in Aberdeen, everybody else shows up too, you know. And people all over North Mississippi have been able to go bankrupt with the bankruptcy headquarters being in Aberdeen. So if comprehensively in everything, we think about the economic viability of rural areas, it also helps provide medical services in rural areas. The two go hand in hand. And unless we think about that up front, it doesn't always get considered. And I have other examples, but I won't go on and on, but that's one of the concerns that I have about this and everything else is the effect that whatever you do in one area has ramifications elsewhere.
Mr. Chairman.
Yes.
I wanted to, that's a very thoughtful comment and I appreciate it. And you're always so thoughtful about healthcare in our state. As it pertains to the charge of our committee with the plans in our state, I just wanted to share a quick story of what it could be. So I've been working with a managed care Medicaid and I say, well, the doctors and the other healthcare providers, they want to live where the soccer team is and where the movie theater is and the university is. And so we have the same challenges in getting healthcare workers to go rural. We've got the Rural Scholars Program, we've got all of that. But if we just take it on its face that right now, take it as it's happening, they're not moving there. How do we penetrate those areas? Have you got a bus with medical supplies on it? They say yes. I said, well, I've got doctors that can help you fill those care gaps. Let's go. And so we're working on kind of the traveling bus, you know, examining the patient in their community. We're doing this managed care Medicaid day for this company and for our members, and we're making sure that they're getting their cholesterol checked or their eyes screened or their heart listened to. And then if they need more, it's not a perfect fix, but there are ways to penetrate that area. And it can be something we can ask the plans to do, to partner with their physician members that live around these counties that are deserts and are making a concerted effort to get into those spaces. It can be an expectation that you're going to go to and not just take your corporate nurse practitioner that you've hired, but actually call on your members to help serve too. And they want to serve. So there are ways to get better, not perfect.
Okay. Is there anything else needs to come before the committee today? I think we've had a great organizational and first meeting of this committee, and I'll ask you to please give me your sheets before you leave today because the committee will work a lot better with your input on issues that we need to study or continue to study. Our next meeting will be 4 weeks from today, September 11th, 2025, in this same room at 10 o'clock a.m. And thank y'all for everyone who's here today, and we stand adjourned. You didn't get one? You get one of those? Okay.